and Research Center. Dr. Sami is very well known of his publications in the field of infectious diseases and medical virology and other related aspects. I will leave you with the Prophet Hajjat to enjoy his talk on global measles outbreaks. Welcome, Dr. Sami.
Thank you very much for a nice introduction. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa barakatuh. Good afternoon. I would like to thank the organizing committee chaired by Dr. Zainab al-Musa for inviting me to speak about the ongoing global challenge of measles, a preventable yet persistent public health threat. Now, the slide shows my objective. I'll start talking about the measles virology and transmission, highlight the infectious nature of the measles virus and how the virus spread. Then I will move to talk about the global outbreak update, region affected, and factor behind the resurgence of measles. Then I will move to talk about clinical presentation and diagnosis, and I will emphasize the key symptom, complication, and approach for the diagnosis. And I will conclude my presentation with management and prevention of measles. Now, rhodiola or measles is acute, highly communicable viral infection caused by the measles virus. The measles virus is member in the Paraxomyridae family morbillivirus genus. This is an envelope virus with a single RNA. And I think if you look for the slide, you will see the simplified schematic diagram of the virus. So going from out to inside, so we have the lipid envelope deriving from the host cell. There is two important glycoproteins on the envelope. These actually two pathogenic proteins. So we have the hemagglutinin, which facilitate the virus attachment to the cell. And then we have the fusion protein, which facilitate the virus to penetrate the cells, causing infection and spreading the virus from cell to cell. Then we will have the matrix protein, which is very important for viral assembly. Then you will have the nucleocapsid, which really protect the genome. And then in the core, you will have the genome. Now, there is only a single serotype of measles. So what this means that immunity can be acquired from infection or from vaccination and provide lifelong protection. Now, within the measles virus, there is a lot of genetic variability, which lead to multiple genotypes. Now, the WHO recognized 24 genotypes, grouped into 8 clades from A to H. Now, the genotype D8 and D3 is the current genotype detected during the global outbreak. Now, the good news is that our vaccine prevents all these genotypes. Now, measles is an exclusive human disease, so we don't have animal reservoir, and we don't know, we are not aware about measles carrier. Measles virus is one of the most communicable or contagious virus. It can spread by respiratory droplet and aerosol. So when the virus is in the air or contaminated the surface, it can be viable for 2 hours. This is the bad news. Now, the good news is that the virus can be inactivated by sun and by low pH. Now, people infected with the virus, they are highly infectious 5 days before to 4 days after the rash. Now, the virus enters the body through the nasopharynx and the conjunctiva. And measles virus has exceptional high basic production number. So one infected person can transmit the virus to up to 18 susceptible persons. So 90% of susceptible household contact will develop the illness. Now, this slide shows the WHO map showing the global incidence and outbreak in the 6 WHO region. And the various blue shade represent or indicate the incidence of measles per 1 million population. So you will see the dark blue represent region with large outbreak, and what you can see also the 10 countries with large ongoing outbreak. Now Saudi Arabia, as you can see, we had major outbreak in 2023. I will talk about that break with the next slide. COVID-19 pandemic, there was significant disruption in measles distribution of the vaccine, coupled with significant increase in vaccine hesitancy and the anti-vaxxer group. All these combined led to decreased uptake of the vaccine and large number of susceptible population. So measles remain the leading cause of deaths in children. An estimate of 107,500 measles lives lost in 2023, primarily in children less than 5 years. Keep in mind that measles is preventable with just 2 doses of vaccine. Now, this slide showed the WHO UNICEF estimate of national immunization coverage in Saudi Arabia as of 7 July 2022, and this is in children less than 1 year. As you know, Saudi Arabia national immunization program is one of the really excellent programs in the world, and we manage really to provide vaccine prevention from many serious infectious diseases in infant and childhood. Now, what happened that our national immunization program faced some disruption during COVID, and coupled actually with hesitancy to get the vaccine. So in 2023, we had a large outbreak of measles, above 2,000. Actually, some data indicate that we had actually close to 4,000. And what the good news that the current vaccine campaign, measles vaccine campaign, actually significantly contribute to the decrease of measles case. I don't have a slide, but really communication with public health authority, they say that now the outbreak is under control. Now, what about measles pathogenesis and characteristic? Now, as I mentioned before, the virus enters the body through the nasopharynx and the conjunctiva. The primary site of replication is the alveolar macrophage. And what happened, the virus replicate there for 2 to 3 days. This will lead to primary viremia, which actually take the virus to the regional lymph node. As you can see in this slide, then the virus starts spreading to the lymphoreticular system, liver, spleen, bone, and this lead to a secondary viremia. And the secondary viremia actually give the start of the prodrome phase. So what about the clinical presentation? So after around 11 to 14 days, patient will start having the prodromal phase, which is characteristic by step size increase in the fever. The fever may be initially 38.5, but then actually increase over 2 to 3 days to about 40.5, and you have the 3 C's, cough, coryza, and conjunctivitis. And all these symptoms usually maybe last about 3 to 4 days, and during the prodromal phase, you have complex spot, which is really pathognomic and unique really for the measles. It's punctated blue-white spot in the buccal mucosa at the level of the second molar. It usually disappears by day 3. And then you will have the phase of the rash. The rash starts at the hairline and then spread to the upper neck, to the face, and spread downward and then reach actually the foot and hand. It's a maculopapular rash. Initially, it fades by pressure, then it cannot fade by pressure. And at the end of the rash, there is some scaling, sometimes there is some pigmentation, and in adult, you may see generalized lymphadenopathy. Now, many healthcare providers forget the complication of measles. The complication of measles can be quite severe in three populations. Children below 5 years, pregnant women, they may have abortion or low birth weight, and immunocompromised host. About 20% of children with severe measles require hospitalization. Common complications include diarrhea, otitis media, and we have two types of pneumonia. We have the measles pneumonia or secondary bacterial pneumonia, and actually pneumonia is one of the leading causes of death in children with measles. And a rare complication is subacute sclerosing encephalitis, which may occur 7 years after the infection. Children, they usually have deterioration in their behavior and intellectually. And there is more data coming that measles infection lead to blunted immune response. And many experts believe that it suppresses T cell function, cellular immunity, and there is a risk really to have subsequent infection. So measles is not a simple disease, is not a simple rash. What about diagnosis? So the diagnosis is based on three elements: clinical, epidemiology, and lab. And to confirm the diagnosis, you need to detect the measles virus RNA using polymerase chain reaction, reverse transcriptase, reverse polymer PCR, RT-PCR, and sample obtained from nasal swab, oral swab, or urine are really a good sample to detect the virus. You can do serology, but you have to know about some type of limitation of serology. There is cross-reactivity between measles, human herpes virus 6, and parvovirus. Also, if you do the serology before the rash, you may be falsely negative. So it's better to do the serology during the first 3 days of the rash. I think genotyping is really quite useful. Genotyping is good. First, you will be able to know the source of the virus. You know how the virus is spread. You can differentiate between whether this virus is a vaccine virus or human virus. And many countries, they use it to confirm the eradication of measles. There is certain measles vaccine assay which can detect the genotype. It's only available in WHO and in the CDC. Now, in terms of treatment, there is no specific antiviral. Treatment is mainly symptomatic. Rehydration is important, and then antipyretic is usually given to control the fever, and you have to manage any complication. What about vitamin A? There is a really strong recommendation to use vitamin A, in particular in countries where they have vitamin A deficiency. However, keep in mind that there is some study indicating that in children with severe measles requiring hospitalization, the use of vitamin A would significantly decrease their complication. It's usually given as a 2 dose. You will give 1 dose, and then 24 hours later you give the second dose. And you can see here there is various recommendations for the doses. And what about ribavirin? There is in vitro data indicating that ribavirin can be useful, but this is really based on case report. It has been used, ribavirin has been used in immunocompromised hosts with pneumonia, bone marrow transplant, and also in some patients with measles encephalopathy. It is available as IV or oral. And in this type of population with severe disease, you may see some improvement, but again, this is not something you would like to use it as a routinely, and should be really reserved to high-risk patients. And probably we need in the future to have clinical trial to see whether ribavirin is useful. And again, in all patients, you should be really carefully monitor these patients for secondary infection. Now, measles vaccine is not new. The first MMR vaccine was licensed in 1971. However, really the measles vaccine was licensed in 1963. This is a live attenuated vaccine. It's very effective. So one dose will give you 93% of prevention of measles. It increased to 97% with the second dose. Our routine immunization schedule include 4 doses, which really are very efficient if it's used properly. As you know, it's very important that you have to keep the rate of vaccination above 95%. So you will be able to prevent any drop, then you will run into outbreak. It's a very well tolerated vaccine. In 5 to 15% of the children, they may have fever, which may occur a little bit late, maybe after 1 week or 10 days. About 2 to 3%, they may have transient rash, and the rash will disappear. And again, because it's a live vaccine, it should not be used routinely in children with severe immunocompromised condition. Now, using the vaccine or immunoglobulin can help to manage measles exposure according to the risk group and the timing. So MMR vaccine can be used within 72 hours with initial measles exposure to be really effective. It can really either prevent or modify. And immunoglobulin is available either IM or IV and should be used really within 6 days. Most of the time it's used in high-risk patients. So let me summarize. Measles is a highly communicable disease which causes significant global health impact. It's a very important really that to have a strategy to control vaccine hesitancy, which really it is the drive force for all outbreak. And we have seen significant delay, whether delaying MMR vaccine because all believe about autism or the hesitancy because of misconception about the vaccine. It's very important to sustain, achieving and maintain high immunization rate above 95%. It's very important to strengthen our routine immunization. Actually, we succeeded all these years. We have one of the best immunization program, and we need really to enhance surveillance. Surveillance is the best way for early detection and for confirmation, and then you will have other plan really to control, like the campaign now can be is really very successful. And again, we need really global commitment to the eradication of measles. I would like to leave you with the quotation from Professor Stanley Plotkin, a well-known professor of pediatric infectious disease and vaccine developer. Quote, "The impact of vaccination in the health of the world people is hard to exaggerate. With the exception of safe water, no other modalities, not even antibiotic, has had such major effect on mortality reduction and population." Thank you very much.
Thank you, Dr. Sami, for your informative presentation about measles with our natural Saudi immunization recommendation. Now, my pleasure to present Dr. Ali Al-Barrak, consultant in internal medicine and infectious disease in Prince Sultan Military Medical City and General Director in Saudi National Center of Disease Control, also Associate Chief Editor in Saudi Medical Journal. He will present RSV in adults, emerging challenges and health impacts for RSV.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you very much for the organizing committee to asking me to present this topic, and thank you for Musa. I appreciate Musa. Birran bi waliday. My father was my father and my mother was very close to the Aziz and Sarah Musa. We were in the eastern province, and they were the disease was a colleague to my father in the military, and we were living close together. So over the last 2 days, we've been talking about the risk of the dust, the land, what's the risk from them, what's the risk from the water that we heard today. And now, over the last 2 topics, we talk about the air transmitted disease. So RSV is one of the new emerging concern. I mean, it has been there for a long time. We said that we were not bothered by it as an adult. We saw some outbreaks that happened in immunocompromised patients, but in pediatric they will be suffering and complaining of it for a long time. New things has happened. First, I want to do a disclosure. I had some work with some of the companies regarding the pneumococcal disease. I had supervised at one time the Center for Infection Control and Prevention at Ministry of Defense, and also work in different committees. I received the RSV vaccine 2 months ago, so you know my age now. This is my grandson, who's Ahmed, who had been now 2 years and a half. And for the last 2 years, I have been suffering recurrent respiratory infections, probably because he's bringing it from the daycare. So the questions that we're going to be addressing is the disease, is it in home, and also the clinical approach to cases and what are the challenges impact in adulthood. I will conclude with this conclusion so that if you'd like to have a nap, this is the time, and I will be asking you questions at the end. RSV in adult is an emerging public health concern with increasing recognition and its serious health impact in special population, addressing the diagnostic gap, raising the awareness for the vaccination and prevention, improving the vaccine uptake, and advancing the antiviral treatment, which we don't have much, are very crucial steps in mitigation of the burden of RSV infection in adults. So it was first discovered as a bronchiolitis cause in the children in the 1950s, found to cause only mild infection in young adults as part of families, clusters. It's not discovered as a serious, except in the late 90s, where there were more immune-compromised, there were more recognition of RSV in adulthood. Since then, has been suggested as a cause for serious illness in community dwelling older adults, and also for those who are presenting with a cardiac or respiratory decompensation coming into the hospital. In the state, it has been estimated that there is 60 to 160,000 hospitalization per year. There has been up to 10,000 deaths per year. And in healthy adults, usually almost mild symptoms consistent of upper respiratory tract infection, some hoarseness in the voice, symptoms usually duration of 5 days. But adults are at increased risk when they have chronic diseases like cardiorespiratory, neurological diabetes, chronic lung disease, chronic kidney disease, if they are resident in nursing home. The person with advanced age, more than 75, has been recognized as one of the most higher percentage of RSV burden of the disease, and also hospitalization / also mortality. RSV also makes separate underlying disease like asthma, chronic obstructive pulmonary disease, congestive heart failure. RSV does not confirm long-term immunity, unfortunately. Children who are less than 2 years, they have multiple attacks of RSVs, and also adults could have multiple exposure to RSVs, and they do not protect themselves. There are 2 types of RSVs, A and B. It is not important to know which one of them, because the vaccines are available now cover both of them. It has been estimated that it is the 4th most common viral pathogen after influenza A and B and COVID, and usually, as I said, causing mild symptoms with some kind of hoarseness. The R naught is around 3. It's more than influenza. And it is spread by droplet and also by contact with the secretions of patients that are on the tables or tissues. The viral shedding is 3 to 8 days, but it longer for those who are immunocompromised, and especially in older adult and infant. Unfortunately, RSVs is coincide with influenza, so you might see both of them or one after the other. So it is the same winter time in Saudi Arabia. It starts in late October and end up in around May, April, May. It's the same time for influenza. Coronavirus is also happening at the same time. This is the version of vaccine in Singapore from 2014 to 2018 for those who have been tested for influenza and they are negative. So they did the RSVs, and as you could see, when 45 to more than 65, there is an increase of cases of RSV in that group. For those who have been hospitalized from 2019 to 2023, there has been, with the blue one is from 50 to 64 years of age, the orange one is more than 65. You could see that there has been more cases in those who are more than 65. And you could also appreciate that in 2020-21, there was a drop of cases, probably because of the segregation of people and not much of exposure happening between the population. But it has resurged again after the 2023. This is also the adjusted RSV associated hospitalization per 100,000 in the season of 2016 to 2017, and it also showing the same thing, more in those who are more than 65, very higher in more than 75 years of age. Comorbidity increasing risk of hospitalization in those who have stroke or have cardiopulmonary diseases, and also with a chronic lung disease and hematological malignancies. And you can see here that with the RSV versus influenza, it's more with RSVs that they are decompensated and had higher hospitalization for those who had more than 85 years of age, and also versus the influenza. The other issue with other than for the RSV infection is, as we said, the decompensation of the underlying disease, and also for the secondary bacterial infection. From 348 who had evidence of viral infection, of those who had RSV positive, 61 had a single viral infection, 18% had another bacterial infection, 21 had flu-means suggestive of bacterial infection. And more than 90% received antibiotic as part of the treatment, which is also another pressure on use of antibiotic for this viral infection. The other issues with RSVs is the difficulty of diagnosis. In pediatric, they were lucky that they have antigen testing where they could pick up the cases, but for adult, unfortunately, it's not so sensitive. So we rely on real-time reverse transcriptase PCR, which is more sensitive in the adult population. Serology is usually used for research purposes, and viral culture is less commonly used. These are some of the tests, and you could see here that it was only 0.29% for the root sensitivity versus 81 for those who are in the children in multiple studies. So the burden of RSVs in older adult is underestimated, because previously, 2 years ago, nobody would be testing for RSVs, because we don't have treatment and we don't have anything to do with the prevention measures. Little motivations to make the diagnosis, and that also had changed with the use of multiplex and knowing those who had respiratory illnesses, doing the multiplex, knowing exactly what's the cause of the attenuation or the respiratory infection. The RSV management used to be giving steroids for those who had stridors or having wheezing, which is very common with the RSVs, especially with those who are underlying disease, humidified oxygen, and bronchodilator. There were not much things to do for the adult. In selected immunocompromised, steroid presently has been tried, but it is not endorsed or indicated for that age. Immunoglobulins also have been used in some experimental therapies. So it was mainly supportive, ribavirin being used only in life-threatening RSV infection and immunocompromised. And it's, as you know, it is aerosolized and it has to be very done in a special situation. These are the treatment targets for the new molecules to RSVs. If it's still under investigation, it has a long way to reach to treatment for RSV. This is as of September 2024. Those who are in the market, those in the red, and there are 3 vaccines that are available. I will be talking about it briefly. And there are 2 immunoprophylaxis available, which is used only for pediatric. It's not yet approved for the use of the adult. As you can see, there are not much of adult interventions regarding the immunoprophylaxis. These are the 3 vaccines, Pfizer, GSK, and Moderna. Pfizer and GSK vaccine was introduced in 2023, approved, and all of them are for people who are aged than 60. Pfizer has got an indication between 18 to 59 for those who had high risk for RSV disease, which is underlying cardiac pulmonary disease, and also for pregnant women at 32 to 36 weeks to prevent neonatal RSVs, which is not approved in Saudi Arabia yet. For GSK, they have loaded up to 50 to 59. Hopefully, with the new studies, that they will come to the lower age as Pfizer. For the Moderna, it's only for those who are more than 60 years of age, and it's just newly approved in 2024. The chain of infections for us as infection control and infectious disease is when we look into the reservoir, where are the pathogens, which is usually the young children who are playing with the adult and spreading the infection to the adult. And in children who take the virus for longer period, so that they could transmit it to the elderly adult or those who are immunocompromised. And the mode of transmission is by direct contact, so very important for hand hygiene. So why would we immunize, why would we need to immunize adults for RSVs? Is to protect infant for the pregnant ladies and also for all the adults who are either at age of certain age and also certain comorbidity. This is just a repetition. Those who are in the blue is the Saudi FDA approved, which is adult more than 60 years of age, and for the other vaccines, also the same thing is for only for the 60. Soon to rethink about the pregnant ladies. And this is for the CDC recommendation. So are we aging as a Saudi national? An hour and a half ago, the national statistics of Saudi Arabia has just announced that 2024, we have 35 million population on the ground of Saudi Arabia. 19.6 are Saudis. So do we need to vaccinate our elderly population, which is around 3% to 5%, which comes to around 1.6 million population? Do we need to vaccinate them all? What's the burden of the vaccine? So, Fiat Kibar Sin, those who are elderly more than 65, soon to be there. These are the population that came from the age. So when we take more than 75, we have around 288. 200,000 are more than 70 years of age, and 368 or those who are more than 65 years of age. This population is peculiar because also what you could see there is that those who are 74% of those who are having comorbidity have comorbidity like cardiovascular disease, diabetes, cancer, and hypertension, which is the same risk for RSV. 63% of those who are more than 65, they have at least every 3 months they are visiting health facility. So there is an opportunity to give them the vaccine when they come to the primary care or come to the chronic diseases clinics. So there is an opportunity to give them the vaccine when they are attending these visits. These are also the statistics from those who had diabetes, those who have hypertension, and those who had disease of musculoskeletal system. So why we need vaccination? Because aging is accompanied by a decline in physiological function and the progressive of immune system, more to have obesity, heart disease, cancer. Vaccination for pertussis, influenza, herpes zoster, and pneumococcal has shown that in the US, for those who are more than 50 years of age, could save up to 60 billion of social cost. So emerging challenges for RSV in adult is recognition of the problem, recognition of the underdiagnosed and misdiagnosing of RSVs, severe outcome for those who are in high risk, a lack of awareness of preventive measure, which is a vaccine available, and also that vaccine and treatment access for those that they would need, they are not aware of how to get the vaccine. I will give a question here. If somebody reaching around 60, do you know how to get the RSV? How to know where is the primary care that they have the vaccine? صحتي. So in صحتي there is for appointment, and there is a Naflawi vaccine, and you could present. I took it within 2 hours. I checked it. I found a place beside my workplace. I went there, got my vaccine, and came back. It's very, very easy to get. The problem of co-infections with RSV is also problematic. The health impact of RSV in adult is a respiratory complication, increased mortality risk, cardiovascular effect, admission to hospitals, long-term effect of post-viral syndrome, either with declining of respiratory reservoir. In conclusions, why should older adults get vaccine? Older adults have a weakened immunity, they have increased susceptibility to RSVs, they are getting their grandchildren by that time, and there is an increase in complications post-RSVs. We need to protect them, we need to protect the families. Thank you very much.
Thank you, Dr. Ali, for